Hello, and thank you for tuning into this video about Aqua's programme on improving flow across the whole of the health and social care system. We think this is a really important topic. I know that lots of people out there are worried about achieving the 4-hour standard for accidents in emergency departments, about long waits for people in the system. Interesting, we didn't come at it originally from that angle. We came at it from the work we've done on safety and quality, because there is a really strong evidence base that delays in the system, delays in patients getting the right treatment quickly enough, produce not just a bad experience, but really bad outcomes. Waiting kills. We need to tackle this urgently, not just to achieve a target, but to make sure that we get the best possible care for our patients in the system. Now, a lot of work has been done to try to get a smooth, effective flow of patients through hospital systems. The work of the Emergency Care Support Team, the new national strategy on transforming urgency emergency care is doing some great work, but it really has started and stopped at the front door and the back door of the hospital. And yet, despite that, there continue to be these really serious problems in outcomes, in experience, and indeed in value for taxpayers' money, because we know that delays in patients getting treatment aren't just bad for that individual, they're a bad use of resources as well. And in ACWA, we believe that we need to reframe this challenge. We need to deepen what we understand by flow across the system, and crucially, we need to broaden our understanding of the system itself. So during 2016, ACWA is really fortunate to have received some funding from the Health Foundation to support this work on improving whole system flow. And we're working in partnership with a range of organisations across the UK through the United Kingdom Improvement Alliance, pooling the best knowledge that we have on this topic and working to help ACWA's members and customers bring about improvements for patients and citizens and for the communities that they serve. This is critical as well as the NHS thinks about how it changes in the light of the NHS 5-year forward view. It's great to see that the vanguards, that through sustainability and transformation footprint plans, people are coming together to work in place-based systems of care, developing accountable care organisations or integrated care organisations. And in doing that, they're all really keen to manage the demand from patients more appropriately and to get better value for money. A lot of that work is really focused on the lines and boxes on the organisation charts, on governance and on structures. We think now what needs to happen is that a new operating model needs to sit below those accountable care organisations. We think whole system flow can be a vital part of the new way in which health and social care might operate going forward to fulfil that vision that's in the NHS 5-year forward view. So what do we mean by whole system flow? We spent a bit of time thinking about this. You might have your own definition. We're really interested to hear about that. So do email us here at ACWA. Do let us know your thoughts and ideas. This is our start for 10, our working definition of whole system flow. It's the coordination of all of the resources across a locality to deliver effective, efficient, patient-centred care in the right setting and at the right time. We believe that's what's going to deliver better outcomes, a better experience, and a better use of the scarce resources that we have. So just let's pause for a moment while you're viewing this, listening to this. Just be thinking for yourself, what's your own definition of whole system flow? Is it the same as we've described it in ACWA? Do you have additions, changes to that? And how would you describe your local system? How broad is it? Who are the key stakeholders who you really need to engage? This is one example of work that's going on to rethink the system. This is work from NHS Scotland, one of our partners in the United Kingdom Improvement Alliance. They've got a great programme of work going on this topic. And what they've done is really expand their thinking about the system. On this chart, you can see that the blue bit of the diagram is where the work's traditionally been done. That's about the hospital element. Important to get flow from the A&E department through the assessment unit to the wards and out to the back door of the hospital. But critically, the biggest bit of the system isn't in the hospital at all. It's in the patient's own homes. People with long-term chronic illnesses care for themselves or are cared for by friends and family 365 days a year, 24 hours a day. It's the support that people receive around them in the community to keep them at home, to keep them healthy, to help manage their condition. And sometimes it's support in the community but in an institutional setting before people ever get anywhere near a hospital. That expanded idea of what the system is about is what we mean when we're talking about whole system flow. Now, the structure of the rest of this presentation is really to talk about three aspects of the work that we think are all important and are interrelated. Of course, we think we need to focus on the journeys that patients make from their own home through the system back to their own home again. At the service level, we need to think about how we redesign those end-to-end journeys of care and connect them up much better, get them to flow more smoothly. But the two other critical steps, we need frontline staff who are directly involved in redesigning those care processes and who are making continuous improvements in care day by day for the patients that they serve. And then there are lots of barriers that can get in the way, the money, the information, the way the workforce is set up and designed. Senior leaders in communities need to be removing those barriers so that frontline staff, patients and communities can work together to get a much more smooth and better joined up flow of services, information, patients and resources across the community as a whole. So let's start by thinking in more detail about how you establish flow across a community. How do you join up all the many different elements that a patient needs if they have an acute illness? We know from work outside healthcare, organisations like Toyota who've used lean thinking, that there are things that we can do that will take out waste, will help things to flow smoothly, and that will lead to a much better outcome and greatly improved productivity. And that's certainly true if you think about your own journey as a patient. You might need to see your GP, be referred for an outpatient appointment, have lots of tests, maybe a hospital admission, and then who knows, also care and support at home afterwards from community nurses, maybe even from social services or voluntary agencies. How do you analyse that flow? How do you map it end to end? Who's got responsibility for the processes? How do the resources flow to where they're most needed? How do we make sure that information gets in the right place? And from the patient's point of view, you spend a lot of time waiting and chasing things up. How do we take those non-value adding steps, that waste, out of the process so the patients get a quicker and better experience? All too often from the patient's experience, it looks messy. Anybody who's had an elderly relative through the system, my mother needed a lot of care in the later years of her life, from hospitals, GPs, social care, a fantastic community psychiatrist, latterly from residential and nursing homes as well. And sometimes it felt like, as the family, we were the only people joining all of that up to get mum to access services in the right way, to make sure every member of staff who was dealing with her had the information at their fingertips about her condition that they needed, to make sure that she was seen by the right clinician at the right time, and that, crucially, they had the right kind of level of resources to provide the care that she needed. So we need to find a way of reducing the confusion, getting all of those things to line up so that people like my mum can get the kind of care and treatment they need at the right time, seen by the right person. And all too often that doesn't happen. John Seddon, who's a thinker and a writer on applying lean in public services, has coined this term failure demand. We talk about the NHS being overwhelmed by demand, but is all of it real, genuine demand? Failure demand is demand caused by a failure to do something or do something right for the customer. It's much more under the organisation's control. So if we think about an elderly person, might be my mum again, who's at home, who has had a few illnesses, who gets a bit of an infection, and maybe seen quickly, seen early, with the right antibiotics at home, with fluids, she could have been kept at home, but maybe she's not seen quickly enough. We don't get the services to her. She ends up having a hospital admission. Maybe she gets to hospital late in the day. She waits a long time on a trolley in the A&E department. She waits for a bed in the hospital, and often those patients then deteriorate. They spend a lot longer in hospital than they needed, and maybe not even be well enough to go back to their own home afterwards. A lot of that is failure demand. It's demand that could have been prevented had we intervened early and in the right way. So at this level of the service, what are the things that we can do to bring about improvements? Well, we think that there are lessons that we can learn from other sectors, from lean, from logistics, about how we map and redesign those patient journeys across the system as a whole. Critically, we need to tackle this issue of failure demand, and I'll show you an example in a minute of one local authority here in the northwest of England who are doing some great work on that. We need to deeply involve patients themselves through approaches such as experience-based design and shared decision making. And we think that we're going to accelerate this work if people work together and learn together, bringing together people in action learning sets, coaching them about how to do the improvement, and maybe even borrowing some of the tools and techniques that other sectors use, such as simulation and modelling, to understand the system and to test out improvements before we make them for real on the ground. So I said I would share one practical example. This is from Wigan Council here in the northwest of England, who've introduced what they call the Deal for adults' social care and wellbeing. Like lots of local authorities, Wigan were faced with big cuts, really challenging cuts in the funding for the services that they provide for their residents. And the approach that they've taken to that is to train all of their staff and a new approach, one that fundamentally rethinks the relationship that they have with the citizens that they serve, to get people to have different conversations with those in need of services so that they can deeply understand what it is that matters to the individual and to their family, so that people get offered the package of support that they really want rather than the ones that the professionals think they need. And what they've found is, time and time again, they've been able to deliver services that do meet people's needs, but in a much more cost-effective way. The council now has hundreds of case examples where they've reduced the cost of care packages, sometimes by as much as 50%, but with a great level of improvement in the satisfaction of those residents. It's a really great example of tackling failure demand at the root, of intervening early, meeting people's demands in the way they want to have them met, and getting greater satisfaction and a better use of resources at the same time. So, a number of questions for you to think about this first of our 3 steps, thinking about the service level. Have you really thought about the patient's end-to-end journey, not just in hospital, but from the patient's own home, whether that's actually their home or whether it's in a residential or a nursing home care setting, that journey from home through the services and back again? And in doing that, are all the right stakeholders involved? Health, of course, social care professionals, but not just them, the ambulance service, general practice, community services, community and voluntary organisations, and of course patients themselves and their friends, family and immediate support. And once you've mapped that process, that journey, have you got a method? Have you got a method that identifies the waste, that takes out the waste and improves the flow, makes the journey a much smoother and safer and more effective one? And critically, can we stop people flowing unnecessarily into the system in the first place? Can we keep them healthy for as long as possible? And if they need care and treatment, get that as close to home as possible? Can we tackle that failure demand that exists in the system? So step 1 was to join services up across the patient journey, get a smoother and more effective flow. But to do that, we need the deep engagement of frontline teams, We need each step in the process itself to be capable. If we don't do that, what we get is a better joined up mess, and that might not help patients at the end of the day, might not be as good a use of resources as we'd hope. So we need to use the tools and techniques of continuous quality improvement. We need to train staff in things like the IHI model for improvement, thinking about the changes that we need to make, going through rapid small tests of change using plan, do, study, act cycles, maybe introducing techniques like care bundles to get reliable and consistent care across the system. Now, the Health Foundation 2 years ago funded a big programme of work on improving the flow of people through the system, some great work done in Sheffield and in South Warwickshire, with some really good results. And in both those sites, they invested really heavily in training frontline staff and in providing them coaching to bring about improvements at the level of the ward, the department and the team. There was a real focus on engaging patients, on using data well, on testing out small changes, and what they called the big room approach to bring together all of the stakeholders. So investing in the skills of frontline staff, making sure that each step in the chain is continuously improving, is a key enabler to improving flow. Questions to ask yourself then: are frontline staff from all of the partner organisations all actively involved in working together to improve services? And is that just a committee meeting, or are they trained in a common approach to use an improvement method to focus on taking out the waste, getting a smooth, effective flow? And we know that some bits of the system are under much greater pressure than others. Social care, for example, has seen much bigger reductions in its funding than the NHS. How are you going to deal with that difference in resource availability in the different bits of your system? Something we sometimes forget is most people have not just a physical problem, but some mental health aspects to that as well. We know that sadly for people with a long-term chronic illness, depression is all too often runs alongside that. We know that people with serious mental health problems are much more likely to have untreated physical illnesses. How at the team level are you bringing those issues together? Are you redesigning teams so that physical and mental health needs are addressed in a holistic way? And then the third and final step is to think about the barriers that get in the way of all of this work and the things that we can do to enable and empower frontline staff to make the changes that are needed to get the whole system to flow more effectively. Now, this is something that ACWA's been doing work on for 4 or 5 years with our members in the northwest of England, and our view is that there are 8 very clear domains that can be barriers, there can be obstacles, things that get in the way of organisations working in partnership together, or they can be enablers, there can be things that can really help to accelerate progress. Some of those are quite hard-edged, the anatomy of integration, if you like, the way the service models are designed, the way the workforce operates, information and IT, finance and contractual mechanisms. We know that payment for results for hospitals can incentivise them to treat more and more patients, not keep them healthy and keep them at home. But just as important is the physiology of integration, the softer but not easier domains of culture and governance and patient care and citizen engagement and leadership. And it's really critical that senior leaders are thinking about how they address these issues, because otherwise well-meaning efforts by staff who've been trained in improvement skills, who want to work together to redesign services across the pathway, to maybe move care out of hospitals into the community, those will founder because these barriers are still in place. And ACWA have developed a set of simple measurement tools to help people think, how well are we doing against these 8 domains, what progress are we making, and are the numbers showing an improvement, not just numbers in terms of the health system performance, but in terms of the performance of social care services as well. So at this level, at the system level, we need to think a bit different. This isn't really just about training people to do plan, do study, act cycles. This is a journey of discovery. We need to think about the theory of how large-scale complex systems operate, we critically need to develop people who are effective leaders of systems. We know that the skills that lead you to be a good CEO or good senior leader in an institution aren't necessarily the same as the skills you need to work across a complex system of care. So introducing improvement coaches, people who can support people to work in a different way, putting together communities who are trying to do this, to learn from each other, can be really critical improvement interventions that can make a big difference. And ACRA has published some of this work in conjunction with the King's Fund, and can be found on the King's Fund's website, our paper on system leadership, describing some of the training that we provided, some of the support for communities as they seek to progress on this journey to moving from being separate individual institutions to genuine place-based systems of care where patients flow smoothly through the system, getting the right care in the right setting, delivered at exactly the right time for them. So, another set of questions to ask for yourselves. In your community, are the senior leaders really working to remove those barriers to partnership, working to turn them into things that will enable and empower frontline staff to do their job better? And are the senior leaders putting in place a common language and an improvement method that's shared by all the partners to make that joint journey of improvement an easier one? And are you developing the skills and style needed at every level by effective system leaders, not just institutional leaders? So, in conclusion in this presentation, we think that improving flow of patients, of staff, of information and resources is absolutely critical going forward. It's the key to better safety, better outcomes and improved experience, and also better use of resources, a more productive system at a time when we know health and social care face enormous financial pressures. But we think that only working in a part of the system, whether that part is the hospital or is social care or is community services, just working in a part of a system won't have the kind of impact that we want for patients. It might mean that our best efforts don't produce the results that we want. So we need a really joined up whole community approach, and we would urge you to find those partners you need to find in your local system. Think about the tools and approaches that we've described in this presentation and work together to get the system to flow so you get better care, better health, a better use of resources for your local present population. Thank you.